Hello, Medicos. Good day to all of you. So this is Dr. BK for you, and in today's class I am going to discuss about the deep cervical fascia and the facial spaces of the neck. So we have actually come to the end of this head and neck session. So in today's session, with respect to the deep cervical fascia, I will be discussing mainly about a short introduction of the deep fascia of the neck. Followed by that, I will be discussing about the different layers of the deep cervical fascia. So it is present in the form of this investing, pretracheal, and then the prevertebral layer. And followed by that, I will be discussing about the facial spaces and its clinical significance, because in between these fascia you have some spaces, and its clinical significance I will be discussing. Now, first of all, with respect to the fascia of the neck, so deep to the skin, what you see is the superficial fascia. The superficial fascia of this contains mainly your fat and then superficial vessels and nerves, that is the cutaneous vessels and nerves. And in the neck you have a subcutaneous muscle that is called as the platysma. In case of the face also, what happens, deep to the superficial fascia you have all the muscles of facial expression, and in the face the deep fascia is absent. So we are going to mainly concentrate on the deep fascia of the neck, which is also called as the fascia coli. So here you are able to see the platysma muscle. So deep to the platysma muscle, what you are able to see, that is the investing layer, or now for the time being let us call it as the deep cervical fascia. Now this fascia not only splits to enclose the muscles, okay, wherever it encounters the muscles it splits to enclose the muscles. So that is the main function of the deep fascia. Anywhere in the body you can see them, actually they actually cover the muscles. Okay, now not only they cover the muscles, they also actually enclose the vessels. Okay, and then certain viscera also, glands, and also the viscera in the neck. Okay, these fascia also at certain places splits to enclose certain spaces. Okay, so facial spaces, mainly what happens, they split, or they are the spaces in between these fascia, because the fascia runs in different planes. So in between them what happens is you have some spaces which we can call it as the interfacial spaces. Okay, so knowledge of these spaces is very important, mainly to actually know the spread of infections from one space to other. So if any part of the neck is affected due to infection or abscess formation, then naturally we should have thorough knowledge. So from this place where the infection can actually track or spread, what would be the possible routes. Okay, so in the neck, as I told you, the fascia is disposed into three layers. So immediately deep to the superficial fascia and the platysma muscle, you see the investing layer of deep cervical fascia. Okay, so that is one layer, and deep to that you see the pretracheal layer. Okay, so that is the pretracheal layer immediately in front of the trachea, and called as the pretracheal layer. And more deeper plane, what you see is the prevertebral layer, because it is present immediately in front of the vertebra and the prevertebral muscles immediately lying in front of the vertebra, they are called as prevertebral muscles. And since that fascia covers uh, that part mainly, that is called as the prevertebral layer. So the fascia or the deep cervical fascia is disposed into three layers from superficial to deep: the investing layer, followed by that the pretracheal layer, and then the prevertebral layer. Now, first let us try to trace the investing layer of deep cervical fascia. Now it completely surrounds the neck like a collar. Okay, so it completely surrounds the neck like a collar, which you are able to see, and it is attached posteriorly to the ligamentum nuchae. Okay, it is attached to the ligamentum nuchae posteriorly. Superiorly, it will be attached to the lower border of the mandible. Okay, and then it continues to the mastoid process, external occipital protuberance, and that is the superior nuchal line. So up to the superior nuchal line, and in the posterior midline, what you see is the external occipital protuberance will be the superior attachment of the deep cervical fascia. So when you trace the fascia, let us start from one point. From any point we can actually start, but we will do it from the anterior midline. So here you are able to see a section of the neck and a transverse section of the neck. Okay, so which has been cut horizontally, and you're able to see the impressions of the sternocleidomastoid. That is your cervical vertebra, spine of the vertebra. So inside that you have the in the vertebral canal, what you see is the spinal cord. So these are all the muscles, and in front midline of the neck you see the thyroid gland, trachea, esophagus, and laterally what you see is the carotid sheath with its contents. Now let us trace this fascia, which you are able to see in the brown line is the investing layer of the deep cervical fascia. Okay, and immediately deep to it you are able to see the yellow color one lined fascia is the pretracheal fascia, and more posteriorly this fascia what you are able to see is the prevertebral fascia. Now, if you trace in the midline on either side, the investing layer is continuously. Okay, it is continuous with the opposite side. Either way, you go from the midline, anterior midline. Okay, then more laterally, if you trace, what happens? It splits to enclose the sternocleidomastoid muscle. Okay, so it splits to enclose the sternocleidomastoid muscle, and then again it unites, and here it forms the roof of the posterior triangle. So the roof of the posterior triangle will be formed by the investing layer of deep cervical fascia, and again it splits to enclose the trapezius muscle. So I hope you will remember these two are the boundaries, anterior and posterior boundaries of the posterior triangle. And finally, it gets attached to the ligamentum nuchae and the cervical spine. Okay, so mainly it forms the roof of the posterior triangle, and here also it forms the roof of the anterior triangle. So that is your sternocleidomastoid, and these are the infrahyoid muscles which you are able to see here. So your sternothyroid, sternohyoid muscles, and the inferior belly of the homohyoid muscles. So they also receives extensions from these investing layer of a deep cervical fascia. Okay, so mainly that is the horizontal tracing if you actually do it at any given level. Now if you trace the fascia above, so horizontally we have traced, see, you are able to see it as split to enclose the sternocleidomastoid and more posteriorly the trapezius muscle. Okay, when traced superiorly, as already I have told you, it is attached to the lower border of the mandible, But before that, in the region of the submandibular gland, okay, it splits to enclose the submandibular gland. So it forms the false capsule. So it splits under the superficial layer attaches to the mandible, and the deep layer goes deeper to the submandibular gland and attaches to the uh, mylohyoid line of the mandible. Okay, so thereby it splits to enclose the submandibular gland. And here I would also like to mention that so between these layers you also have a space called as the submandibular space. So that we will discuss in the later part of this lecture with respect to the submandibular spaces, spatial spaces. So above in the region of submandibular gland, it splits to enclose the gland and attaches. The superficial layer attaches to the lower border of the body of the mandible. Okay, and in the region further above, if you trace it, in the region of the parotid gland, the parotid region, again it splits. One layer passes above the parotid gland and attaches to the zygomatic arch. Okay, and this part, that superior layer which passes on top of the parotid gland, uh, is also continuous above the masseter and fuses with the epimysium of the masseter. So this is a very tough fascia forming the parotidomasseteric fascia. Okay, so it splits and the superficial layer attaching to the zygomatic arch. So this fascia is very strong over the parotid gland and the masseter muscle and called as the parotidomasseteric fascia. And the deep layer attaches to the tympanic plate and the styloid process, and you see a thickening of this fascia from the uh, angle of a mandible to the styloid process, and that is called as the stylomandibular ligament. Okay, so with respect to the stylomandibular ligament and also the false capsule of the submandibular gland, kindly refer to the respective lectures. On the submandibular gland, I would have discussed again in detail about this splitting of the fascia. Same way in the temporomandibular joint, I would have discussed about the stylomandibular ligament. So stylomandibular ligament is nothing but the modification of investing layer of deep cervical fascia. So here you should remember one thing is the tough parotidomasseteric fascia which you are seeing on top of the parotid gland and the masseter muscle. Okay, so that is mainly the superior attachments of the inner layer of the deep cervical fascia. Now, when you come inferiorly, it is attached to the manubrium sternum. Okay, it is attached to the manubrium sternum, and when it is going to attach, just prior to that, it splits into two layers. Okay, so these two layers encloses a space, and the contents of the space is you are able to see the two anterior jugular veins. They actually you are united by an arch which is called as the jugular arch. Okay, and then you see the origin of the two sternocleidomastoid muscles and the interclavicular ligament. Okay, all these things you come across in this space. So mainly when traced below, it splits to attach to the manubrium sternum, and more laterally it is attached to the clavicle, and behind it is attached to the acromion process and the spine of the scapula. Okay, so continuous line along the clavicle and then the spine of scapula, acromion process, and in the midline again it attaches to the ligamentum nuchae. So now I told you prior to its attachment to the manubrium sternum, the fascia splits to enclose a space which is called as the suprasternal space of Burns. Okay, so this is the suprasternal space of Burns. In the midline you are able to see the investing layer just splits to enclose the space, and the content of the space which I already told you, which consists of the jugular arch, jugular venous arch. Okay, So laterally, as I told you, it splits to attach to the clavicle and then the spine and the acromion process of the scapula. Now, immediately above the clavicle also, the space, the fascia splits before attaching to the clavicle, and that is called as the supraclavicular space. So, the supraclavicular space is again between the two layers or the splitting of the investing layer of the deep cervical fascia. Okay, and it splits to enclose one muscle which is running here called as the the inferior belly of the omohyoid muscle. Okay, so this space is again pierced by the external jugular vein. So what is superficial pierces the fascia, and then what happens is it is going to drain into the subclavian vein. One more structure is the supraclavicular nerves. So while the vein from superficial it goes deep, the nerves which were deep from the cervical plexus pierces the fascia and then becomes superficial to supply the skin over the pectoral region and the shoulder. Okay, so the contents are mainly the supraclavicular nerves, which are three in number: medial, intermediate, and the lateral supraclavicular nerves, and then you have the external jugular vein. So, if you look if you actually compile the all the facts about the investing layer of the deep cervical fascia, you find out something interesting. It is actually called as the fascia of two because everything is 2-2. It splits to enclose two muscles. So one is the sternocleidomastoid and another one is the trapezius muscle. Okay, it splits to enclose two glands, mainly your submandibular and the parotid gland. So submandibular and the parotid gland, it splits to enclose two glands. It encloses actually two spaces, suprasternal space of Burns and other one is your supraclavicular space, and it forms roof of the posterior triangle as well as the anterior triangle, and it also shows two modifications or two fascial slings. So here you're able to see that is the supraclavicular space, and it forms a sling for the omohyoid muscle, and one more sling which you are able to see is the tendon of the digastric. This is the posterior and that is the anterior belly, and you're able to see it forms a sling through which the intermediate tendon attaches the two bellies to the hyoid bone, and this is the omohyoid fascia. So the posterior layer of the omohyoid fascia is continuous with the clavipectoral fascia. Okay, posterior layer of the omohyoid fascia. So it forms two fascial slings and it also forms two thickenings. One is the stylomandibular ligament, and one more thickening over the masseter is the and the parotid gland. Masseter and the parotid gland is called as the parotidomasseteric fascia. Okay, so all two muscles, two glands, two spaces, and the roof of two triangles, it forms two fascial slings and two thickenings. So that is why it is also called as the fascia of twos. So I think with this we have actually completed the investing layer. Now we will actually proceed to the pretracheal layer. So here you are able to see the infrahyoid muscles, and in front you are able to see the thyroid cartilage, and you will see the thyroid gland which is all covered in front of the trachea, and this laryngeal cartilage you have a fascia called as the pretracheal layer. So since it is present in front of the trachea, it is actually named so, pretracheal layer of deep cervical fascia. Now, this fascia splits to actually enclose the thyroid gland. So now you are able to see that is the isthmus of the thyroid gland, and that is the lateral lobes of the thyroid gland, which is surrounded by the pretracheal layer of the deep cervical fascia. So in front, that is your trachea, and behind the esophagus. So in front of the trachea, you're able to see that line, purple color line. which splits to enclose the thyroid gland. Okay, and superiorly, what happens after enclosing the thyroid gland, it attaches to the oblique line of the thyroid cartilage, and further above it attaches to the hyoid bone. Okay, attachments of the pretracheal layer. Now from the posterior part, you have a thickening of this fascia from the lateral lobe of the thyroid to the hyoid gland, called as the suspensory ligament of belly. Okay, so here you are able to see the pretracheal layer of the deep cervical fascia. So it splits to enclose the thyroid gland, and below, if you trace these fascia, and it is merging with the fibrous pericardium of the heart. So it enters the thorax via the superior mediastinum. Okay, so you have superior mediastinum. Mediastinum can be classified into superior and inferior. Inferior is again divided into anterior, middle, and posterior. So this is actually, the heart is present in the middle mediastinum. So the pretracheal layer, that green color line, what you are able to see here, enters the thorax and merges with the fibrous pericardium of the heart. Okay, so laterally also you can see it extends. Laterally it extends, and it might form your carotid sheath, anterior wall of the carotid sheath. Okay, and in the thorax it might be continuous with the fascia covering the apex of the lung, which is called as the suprapleural membrane. Suprapleural membrane. Okay, so extends laterally to merge with the investing layer, and that is your investing layer, which you are able to see here. So it might merge with this investing layer and contribute for the formation of the carotid sheath. So what is the content? Mainly, when you look at it, the thyroid gland is actually present. Whereas the parathyroid, the position is variable, especially the inferior parathyroid. Okay, so superiorly it attaches to the oblique line, and further above it attaches to the hyoid bone. Inferiorly it passes to the thorax from the superior mediastinum. So contents are mainly thyroid gland and the thyroid veins, especially the inferior thyroid veins, which are present uh, in this pretracheal layer of the deep cervical fascia. Okay, so now since this fascia encloses the thyroid gland and attaches to the laryngeal cartilages, what happens is when the larynx moves, naturally the thyroid gland also moves. So that is how you can demarcate between swelling or of the thyroid, or whether it is an enlarged lymph node. So you ask the patient to actually swallow, and when the swelling also moves, then it should be associated with the thyroid gland. Okay, so posteriorly, near the posterior border of the lateral lobe, it is very much ill defined. The pretracheal layer is very weak. So any mass or tumors of the thyroid gland tend to actually extend posteriorly rather anteriorly. So we have finished with the pretracheal layer. Now we are actually proceeding on to the prevertebral layer. So here able to see the cervical vertebra. In front of that you see that fascial layer, and that is called as the prevertebral layer of deep cervical fascia. So that is actually present in a more deeper plane. So more superficially we have seen the investing layer, and then what we have seen is the pretracheal layer. So now posteriorly what we are going to see, or what we are seeing in this picture, is the prevertebral layer. So since it is present in front of the vertebra and prevertebral muscles, it is called as the prevertebral layer. It is attaching to the base of the skull, so that is the clivus you are able to see. So mainly it is attaching to the base of the skull, and if you trace it below, it merges with the anterior longitudinal ligament, so passes from the neck to the thorax to the posterior mediastinum. So here we have seen the superior, and then merging with the fibrous pericardium, which is situated in the middle mediastinum. Here you can see the mainly the prevertebral layer entering into the thorax and merging with the anterior longitudinal ligament, and the level of this fascia, it extends up to the first three thoracic vertebra. Okay, so merging with the anterior longitudinal ligament, which is present immediately in front of the bodies of the vertebra. So a cross section, you will have a better idea about this prevertebral layer of deep cervical fascia. So posteriorly, it is attached here to the ligamentum nuchae. Okay, and from there passing deep to the trapezius muscle. So this inner layer you are able to see passing deep to the trapezius. So it covers all the muscles. Okay, so mainly you are able to see the paravertebral muscles, and it forms the floor of the posterior triangle. This is the roof of the posterior triangle floor. Deep to the floor of the posterior triangle, you see the muscles of the floor. So mainly your scalenus medius, scalenus posterior, levator scapulae, and splenius capatus. So all these muscles are covered by the prevertebral layer of the deep cervical fascia. And when it comes to the transverse process anteriorly, and from there more medially, if you see the fascia splits into two layers. Okay, so up to the transverse process you can see it as a single layer, and beyond that it actually splits into two layers. Okay, so prevertebral layer of deep cervical fascia. So further, if you trace it in the anteriorly, it has got an anterior layer which you are able to see that red line, and then you are able to see the blue line. So the anterior layer is actually called as the alar fascia, or the alar layer of prevertebral fascia, which is present immediately behind the pharynx. Okay, and the pharynx is actually covered by a fascia which is called as the Buccopharyngeal fascia, and this alar fascia is attached to the Buccopharyngeal fascia. You're able to see both of these have fused. The alar fascia actually attaches to the Buccopharyngeal fascia in the midline. Okay, in the posterior to the pharynx, in the midline, it is fused. Okay, so then posterior to this alar fascia only, what you see is the thick prevertebral fascia, which covers the prevertebral muscles. Okay, the the retropharyngeal space actually is present between the alar and the prevertebral layer. Now that is again, there are various views. So some authors claim that it is present between the alar and the prevertebral layer, but some authors claim that it is present between the buccopharyngeal fascia and the alar fascia. Okay, and what actually is present between the alar and the prevertebral space is actually called as the danger zone. So that we will come to it later. So here you are able to see the prevertebral fascia, it splits to actually two layers. In front is the alar fascia, and that is the thick prevertebral fascia. So this is your retropharyngeal space, which is present immediately below the pharynx. And the retropharyngeal space will actually communicate laterally with the lateral pharyngeal space on either side with the lateral pharyngeal space. Okay, so that is the retropharyngeal space which you are able to see here, which is present between the alar and the buccopharyngeal fascia. This alar and buccopharyngeal fascia in the midline is actually fused, so you have retropharyngeal space on either side of this midline fusion. Now here you are able to see in between the scalenus medius and what you are able to see, the scalenus medius and the posterior muscles, the trunks of the brachial plexus. So when these enter into the upper limb, they will carry along with them the covering or prolongation of these fascia, and that is called as the axillary sheath. So the axillary sheath mainly consists of your brachial plexus and the axillary artery, but not the axillary vein. Okay, so so we are finished with these three coverings, mainly the investing layer, followed by that the pretracheal layer, and followed by that the prevertebral layer of deep cervical fascia. Now here you are able to see carotid sheath. So it is a tubular prolongation of the deep cervical fascia which covers the great vessels, mainly your common carotid artery and then your internal jugular vein and internal carotid artery. Common carotid continues as the internal carotid. External carotid pierces the fascia and comes out. Okay, so if you look at the sheath, it is actually wedged between the pretracheal layer. You are able to see that is the pretracheal layer, and that is the investing layer, and posteriorly you see the prevertebral layer. So between these three, so again some authors claim that the anterior wall is formed by the investing layer, or some people tell it is pretracheal layer. Posterior wall is by the prevertebral layer. But all these three are surrounded and very much in close proximity. So naturally these three contribute for this carotid sheath. Okay, so here you are able to see the great vessels, mainly your laterally you see the internal jugular vein, and that is the common carotid continuing as the internal carotid, which is surrounded by a tubular prolongation of the fascial sheath. Okay, so posteriorly what you are able to see is the prevertebral layer. Okay, anteriorly you will have the investing layer. So this sheath goes up to the base of the skull, margins of the carotid canal, and below if you trace it, it merges up to the arch of aorta. Okay, so the fascia is thick over the artery and thin over the vein to allow expansion of or the dilatation of the vein, and anteriorly it will be related to the ansa cervicalis, and posteriorly the cervical sympathetic chain is present. The cervical sympathetic chain is behind this carotid sheath but in front of the prevertebral fascia. So it is not present deep to the prevertebral fascia uh, as in case of the trunks of brachial plexus, which is present deep to the prevertebral fascia. Okay, so in front of the vertebra and the alar fascia, between the prevertebral and the alar fascia, you see that is the danger space, which is actually proceeding downwards. So that we will discuss in the facial spaces, which shortly we will be seeing after this buccopharyngeal fascia. Now again, it is a fascia which lines externally the buccinator muscle anteriorly and posteriorly the constrictor muscles. Now again, there is a very much difference of opinion with respect to this existence of these fascia, because buccinator, you know very well, it is a facial muscle. So deep fascia is absent in the face. Then buccopharyngeal fascia, if it is present, naturally when the food enters, the constrictors has to dilate and then constrict the food. When the constrictors constrict, the food which enters as the lower segment of the pharynx, naturally it has to dilate. So any fascia externally will restrict its dilatation. Okay, but some authors claim that the fascia is present and it is not so very thick, uh, because a classification of the fascia arbitrary, it is very much arbitrary. How do you classify a fascia into deep fascia, or because of the presence of the areolar tissue, the thickness varies. So they tell it is a very weak fascia, the buccopharyngeal fascia. Okay, so there are two contrasting opinions as to whether the buccopharyngeal fascia as such is present, covering externally the buccinator and the constrictors of the pharynx. So now we will move on to the second part of today's lecture, that is the facial spaces of neck. Now, these facial spaces, they are lying between the facial planes. So you're able to see carotid sheath here, then you're able to see the prevertebral layer, and then the layer, alar fascia, and the prevertebral layer, which you are able to see here, investing layer, and then the pretracheal layer. So in between these, there are no tissue barriers. So they are potential spaces, which means they are very much communicating with each other, and they actually facilitate the spread of infections because of their communications. Okay, so possible route for spread of infections is mainly through these spaces. So that is why it is essential to have a thorough knowledge of these spaces. So coming to these spaces above the hyoid bone, okay, mainly we have the submental and submandibular spaces. So below the symphysis menti and the submandibular gland, we have the submental and submandibular spaces. Then behind the pharynx, what we have is the retropharyngeal space, and then that is continuous laterally with the parapharyngeal space, and then the prevertebral space. You also have space which is within the carotid sheath, is actually called as the carotid space. There are also numerous spaces, like you also have sublingual space. Then you have masticator space. Okay, so we will try to understand the facial spaces and its communications. First, we will see the retropharyngeal space. So the retropharyngeal space, the name itself suggests it is present behind the pharynx. Okay, so that is the buccopharyngeal fascia and the alar fascia. So between the buccopharyngeal and the alar fascia, you have the retropharyngeal space. Okay, so and as I told you, these two fuses in the midline, so it is immediately on either side of the midline posteriorly. From the base of skull to the, it extends to the mediastinum, posterior mediastinum. You're able to see, so it is extending into the posterior mediastinum. So main contents of this space will be your pharyngeal plexus of vessels and nerves, pharyngeal lymph nodes, retropharyngeal lymph nodes, and then loose areolar tissue. So mainly this space is infected by the separation of these lymph nodes. So when these lymph nodes are infected, then naturally what happens is retropharyngeal lymph nodes leads to retropharyngeal abscess. So swelling, formation of pus in this space. Okay, retropharyngeal abscess. And what happens, that retropharyngeal abscess might actually enlarge anteriorly, um, involving the posterior wall of the pharynx. Okay, so laterally, since it communicates with the lateral pharyngeal space, uh, it can go to the lateral pharyngeal space, or it might pass posterior to the carotid sheath, and it might see deep to the sternomastoid, or below it might actually track into the thorax. Okay, so that is the main spread of route of infections. Okay, from the retropharyngeal space. Okay, so from the retropharyngeal space, it can go to the thorax. Anteriorly, it might swell into the pharynx. Midline swelling it can form. Okay, and otherwise, it might pass laterally to the parapharyngeal space, and deep to the carotid sheath, it might pass deep to the sternomastoid in the neck. Now, the danger space which you are able to see is posterior to the retropharyngeal space between the alar and the prevertebral fascia, and that is actually called as the danger space. And see, that space actually extends up till the diaphragm. So it might extend up to the diaphragm, and naturally any infections of these space, especially from the retropharyngeal space, it might come, and or else from the prevertebral space it might involve, and it might track down up to the thorax, so it might involve the thorax. So from here Actually, it might the infection can spread to your pericardium, fibrous pericardium, or structures in the superior or posterior mediastinal structures. So, since it can involve a very distant and wide areas, it is actually called as the danger space, like your dangerous area of space face you have. Next is the parapharyngeal space, a graphical representation. You are able to see it is somewhat wedge shaped. So medially, you will have the lateral wall of the pharynx, nasopharynx, upper part, and oropharynx. You are able to see here. Okay, medially. Laterally, you will have the parotid gland posteriorly, and then the carotid sheath. Okay, so it is extending from the base of the skull to the hyoid bone. So the boundaries, as it's wedge shaped, I told you, that is the lateral pharyngeal space. Okay, so medially the wall of the pharynx with the palatine tonsil. So, so now you should remember, any infections from the tonsil definitely can spread into the lateral pharyngeal space. Medially, the wall of the pharynx and the palatine tonsil. Okay, laterally and behind you have the parotid gland, and in front you have the mandible with the medial pterygoid muscle. This is the mandible ramus, and that is the medial pterygoid muscle. And laterally, external to the ramus, you see the masseter muscle. So it is limited by parotid gland and then the medial pterygoid muscle. And posteriorly, what you see is the carotid sheath. Actually, the carotid sheath is the one which separates your lateral pharyngeal space from the retropharyngeal space. Okay, so mainly it consists of the maxillary nerves and vessels. So when you look at the clinical significance, the lateral pharyngeal space might get infected from the retropharyngeal space, or pathology arising from this space itself because of certain minor salivary glands or branchial clefts, any anomalies of the branchial clefts, branchial apparatus, or lipoma. So from here, what happens is secondary infections, as I told you, from the palatine tonsil or from the retropharyngeal space, because this communicates to the retropharyngeal space posterior-medially. From here, infections can go to the submandibular space and also to the parotid space above. Okay, so that is about the parapharyngeal space, or the what do you call, the lateral pharyngeal space. So the infections or pus might actually compress the pharynx medially if the pathology is proceeding medially, or sometimes it will displace the carotid sheath if the abscess is actually extending posteriorly. Okay, and the parotid gland, it might displace the parotid gland laterally if it is extending posterolaterally. Okay, so that is the spread of infection. So mainly this space communicates to the parotid and the submandibular space. So secondary infections from the palatine tonsil and from the retropharyngeal space can actually infect this space. The next is the prevertebral space. So the prevertebral space posterior to the retropharyngeal space, and here you are able to see prevertebral fascia. So in the prevertebral fascia, in between the prevertebral fascia and the bodies of these cervical vertebrae and prevertebral muscles. Okay, so the contents mainly what you are able to see in this space is a prevertebral muscles, mainly your longus colli muscle, bodies of the vertebra, intervertebral discs, and your vertebral artery. So all these forms the content of this prevertebral space. Okay, so pathology mainly arising from the tumors of these vertebra. Okay, and of course your trunks of brachial plexus and your phrenic nerve is also content of this space. So that is why these brachial plexus, when they come, they bring a prolongation of this fascia as the axillary sheath. Okay, so what happens is involvement of the space in primary tumors of the vertebra, or tendinitis of the prevertebral muscles, or osteomyelitis might all form the pathology, or cold abscess, because of the involvement of the cervical vertebra tuberculosis. So in tuberculosis of the cervical vertebra, you form cold abscess. So the pus from these space, what happens, might actually pass laterally and via the axillary sheath, trunks of brachial plexus, it might also point to the axilla. Okay, so that is the prevertebral space. Next, passing on to the submandibular space. So here above the hyoid bone, the investing layer splits to enclose the submandibular gland as the false capsule. Okay, that is attaching to the lower border of the mandible and then to the mylohyoid line. So that is your submandibular gland. Associated structures is submandibular lymph nodes, and of course you have part of facial artery, hypoglossal nerve. All those things are actually present in the submandibular space. So the roof is formed by the mylohyoid muscle and floor is actually formed by the investing layer of the deep cervical fascia. So that should be your platysma deep to it. So this space continues posteriorly with the lateral pharyngeal space. So you are able to see that mainly the submandibular space is continuous with the lateral pharyngeal space. Okay, so contents, as I told you, submandibular salivary gland and submandibular lymph nodes. So mainly the lymph nodes might get infected or abscess formation in this area due to tumors of the submandibular gland or obstruction of submandibular duct or simply adenitis or a thyroglossal cyst, which is a developmental persistent thyroglossal duct. Now, what is Ludwig's angina? You see a swelling or abscess in the submandibular region due to spread of infection from the lateral pharyngeal space, which is again mainly infections from the tonsil or from the dental caries. So we need tooth decay, infections from that naturally spreads to the submandibular area, forming an abscess which is called as the Ludwig's angina. Visceral space, which is seen in front limited by the pretracheal fascia and posteriorly the prevertebral fascia. So this space which contains your viscera, mainly your thyroid and parathyroid gland, trachea and esophagus. So that is why it is called as the visceral space or visceral compartment. So this communicates with the retropharyngeal space above, okay, and below extends into the superior mediastinum. So this space is actually called as the visceral space. On either side, you are able to see the visceral space, which consists of the thyroid, trachea, and the esophagus. On either side, it is limited by the carotid sheath. So contents, as I told you, trachea, esophagus, thyroid, and parathyroid glands. And infections can spread into the superior mediastinum from this visceral space. Next is the masticator space, the space which is present between the mandible and the muscles of mastication. So you are able to see the medial pterygoid muscle, that is the mandible, and here you are able to see the masseter muscle. So spread of infections mainly from the dental caries, from the lateral pharyngeal space and submandibular space can enter into the masticator space. So it is subdivided into mainly mesenteric space, temporal space, and infratemporal space. Okay, so temporal, infratemporal, and submesenteric space. So here able to see the submesenteric space is between the masseter and the mandible, submesenteric space. Okay, and then here you are able to see, so submesenteric space again communicates with the submandibular space. So communications from the submandibular and lateral pharyngeal space. Okay, and this is your pterygomandibular space, or also called as the infratemporal space. So mesenteric space, submesenteric space communicates with the submandibular and lateral pharyngeal. Okay, next is the temporal space, which is between the temporalis muscle and the temporal fascia. Infratemporal space, here you're able to see between the mandible and the pterygoid muscles, which I showed in the last picture, pterygo mandibular space. that is called as the infratemporal space. So infections from here can actually spread into the cavernous sinus via the branches of the mandibular nerve. Okay, through the branches it can actually spread to the cavernous sinus. And next, some small spaces, parotid space. Okay, so the parotid space which is present between the superficial layer of the investing deep cervical fascia and then the parotid gland. So contains parotid gland and parotid lymph nodes and all the structures present within it, that is the bifurcation, terminal division of external carotid artery, formation of external jugular vein and the facial nerve. All these things are present within this parotid space, that is the parotid region. So this space is extremely painful because of the tough parotidomesenteric fascia. So anteriorly this parotidomesenteric fascia which covers the parotid muscle external, parotid gland externally and the masseter muscle forms the very tough parotidomesenteric fascia. So any swelling due to infections, what happens, causes extreme pain. Then you have the buccal space which is present lateral to the buccinator muscle. Okay, and what happens is lateral to this you have the parotid space and the masseter space. So the buccal space communicates. Mainly content of the buccal space will be buccal pad of fat, and here you are able to see the parotid duct and you have the buccal branch of the facial nerve. So they all form the part of the buccal space. So that might communicate mainly with the parotid space or to the submesenteric space. So I think with this I have completed the facial spaces. So here you are able to see the various retropharyngeal space, and that is your lateral pharyngeal space, and that should be your prevertebral space, and this should be your danger space. Okay, so sublingual space, submental space and submandibular space. Pterygomandibular or infratemporal space, here you will have the submesenteric space. Okay, so with this I have completed the deep cervical fascia and facial spaces of neck, and with this also the head and neck portion comes to an end. So thank you very much for your patient listening. We will meet again in one more lecture.